to you. Just want to extend a big thanks to the panel. Again, another excellent panel, and really appreciate your time and your expertise in sitting on this panel. So we'll move to the final session of the day, and I think this is I think it fits kind of nicely as we were talking about guidelines and talking about dissemination and implementation. And for this panel, what we're going to be looking at is guidelines and the challenges and successes in dissemination and implementation at the country level and the facility level. And I'm going to turn this over doing the moderating is Catherine Taylor, who supports the Merck from Others Product Innovation and Market Access Portfolio as a technical advisor. Catherine, you're very welcome.
Thanks so much, John. Good morning, good afternoon and evening to, I think it's been over 150 participants on the meeting, so it's really exciting to have so much participation. So today, as John said, we've been hearing the latest evidence and new global guidelines around PPH prevention and treatment. And there's a lot of innovation that's been ongoing in this area. But as Debbie highlighted and John mentioned, sometimes these guidelines that are being developed with a lot of hard work and consultation, knowledge of these guidelines is not really reaching policymakers and practitioners at country level. And so in this session, we have three experts in the field of maternal health, both with deep country implementation experience and broad global experience. So we have a great perspective from all three of our experts. I'm not going to read their bios in full. They are on the meeting website, which you found in your invitation. So I would really advise you to go and read those bios. But I'd like to start off the session by introducing Dr. David Neshiwat, who is an obstetrician and gynecologist at the University Teaching Hospital of Kigali in Rwanda. And he heads the Department of Obstetrics and Gynecology and coordinates the clinical activities related to women's health. Dr. David today will be speaking around the issues of the development, dissemination, and relevance of guidelines at a country level. So over to you, Dr. David.
Yeah, thank you, Catherine, for introducing me. I'm really very pleased to be here participating in this PPH community of practice. And today, I'm also very happy to be talking after having had some of the recommendations which are already developed, because we are going to be talking about guideline challenge and success in dissemination and implementation. So we have seen guideline being developed or the recommendation, but now the main challenge is dissemination. So next slide, please. With my slide, as a clinician, obstetrician, and gynecologist, I would just talk about the guideline development process as really being an evidence-based practice area. It's quite important that we as a clinician be able to understand at least how guidelines are developed and know the strategy which are used, then look at the barrier which affect its implementation at different levels of practice, because it's quite important that they get implemented. Next slide. So when you look at guidelines, they are really very important tools which are used to improve health care and health outcome. They allow clinicians, different individuals to make sure that regardless of the geographical location of the patient, the care is the same, is similar. It's really something to avoid when a patient with similar condition gets different intervention and sometimes get harmful intervention or does not really receive the right intervention. So as you understand, guidelines really are very important as they try to guide us to know which is the correct intervention, which is the right procedure to make sure that the healthcare and the outcome is better. So we have globally different UN agencies, NGOs, donors, and professional societies which keep at producing guidelines daily every time, and we have a very big number of them aimed at improving maternal and neonatal care. However, when you look at the practice, some of them does not really result into practice. So this is really the main area where we are looking at. So there is a number of questions which can be asked about how guidelines are communicated, how guidelines are disseminated, and how relevant they are and practical. So why aren't the end users using guideline at optimal level, which is needed? Next slide. So talking a little bit about guideline development process, because again, it is quite important, but that end users also have the idea of how this is a long process, which need to be serious to make sure that the recommendations are correct. First of all, they have to be a group, a guideline development group, as you have been presented in different presentations like on YouTube and so forth. This guideline development group has to be made of various individuals, including a panel of experts, including people who are just going to be looking at the evidence, and people who are just going to be overlooking the guideline development budget and so forth. So once these people are there, it may start before, there is a need to identify the topic. So as we are talking about postpartum hemorrhage, let me go to treatment, because we have a priority in the prevention of postpartum hemorrhage, but also in the management. So let's say that we find as the priority the treatment. So at this point, this group is just going to look at the different treatment options, different intervention to make sure that the maternal deaths due to PPH can just be reduced, that the outcome can be better. So the team decide or determine the guidelines scope and then clinical question for literature review. So this becomes quite important. Let's say that people are just working on uterine balloon tamponade or tranexamic acid. That is the intervention. So they also, to determine the question, they need to use the PICO formula where they're going to look at the population at the intervention and then comparison and the outcome. So as we've seen in the previous presentation, some people might be exposed to uterine balloon tamponade and others not. So what the literature does, when the question has been identified, they just try to look at different studies and consider different level of evidence to ensure that they are going to give us a summarized evidence and recommendation. So that is the process which comes in when they're identifying the questions. So then after that, after looking at different studies and the outcome, then they make recommendation. So the next step is again, review, comment, and approval. This is quite important because they need to make sure that there are people, sometimes including external experts who have not been involved into the guideline development group, so that they can make comment, they can look at how it was done, then before the publication. Then the next step is publication, then periodic review. So next slide, please. Next slide.
I think Dr. David's camera has frozen. Can you hear us? Oh, he's gone off the radar here.
We can see David's camera again. David, can you unmute and try again? We lost you for a moment.
Okay. All right, thank you. Yeah, so this next slide is similar to the slide we had because guidelines have to have some standards. The question have to be relevant, it has to be transparent. Then they need to be a guideline development group. Then they need to have a planning. So the development, as I said on the previous slide, is based on forming the question, then deciding on the evidence. So they look at different evidence before they can make recommendation. Then there will be a review which can be done by independent review, then public consultation, then implementation, which is really an important part of the guideline to make sure that the guideline is successful, then updating the guideline. So as you can see, really, it's a very complex process which is the complex and fascinating. So now at the end, the next step is the implementation, which we need because the documents are quite important. So next slide, please. So the next slide talks about now once the guideline is developed, how the dissemination is done. So it can be done through the publication. They can have sometimes printed copies which are shared. There is online communication, audiovisual communication. Sometimes they can just be done as emergency communication, then news and social media. So all of these are strategies which are used, and most of the time we see them being implemented. So the guardrails of this, so why don't we have a guideline implemented? So let's go to next slide to look at some of the barriers. So the barriers can be divided into different categories. And I can say that these can be different from region to region or from hospital to hospital or country to country. But sometimes we have like personal factors, like lack of awareness, where people have not really managed to get the guideline or not informed. There's sometimes lack of familiarity with the guideline or lack of agreement or misunderstanding, and then sometimes lack of skill, understanding, or lack of running culture. So these are really personal reasons why sometimes guidelines is not implemented. So there is, again, a guideline related, like accessibility. So once the guidelines is developed, is it accessible? Sometimes it is really like a guideline of 200 pages, which definitely becomes hard to read. But again, recommendation. So despite the evidence, sometimes recommendation can be a challenge. So if the evidence is not strong, so recommendation might not be also, high. So this becomes definitely a problem, or just when there is lack of evidence. And sometimes there are also some external factors which you know, like workload, time restriction, lack of facilitation, lack of collaboration, and organizational constraints. So all of this becomes sometimes hinder the implementation of the guideline. Next slide. So we see some, this time we have already started seeing some positive practice, which are really promising, like increasing the ownership, which is really one of the big things, to make sure that the people who are just going to be using the guideline owned really started to make a difference. And we see this in different countries where some of the guidelines, I can give example of WHO guidelines, where they are really being owned by the countries. So again, some countries are putting measures like continued professional development, where again, they emphasize on development of guidelines, or they use them as part of the continuous, the CPD. Again, they get used at country level sometimes when there is, you know, when the medicine grows, especially in maternal health, when the outcome is not good. Sometimes having used the guidelines save the providers. The next step is accreditation and facilitated adaptation of global guidelines at country level, where we see experts from the people who have developed the guideline coming and joining the country level. Next slide. So at the facility level, again, we see different practices, which really leads. So we know that accreditation of the hospital is quite important, because this is associated with standards. And when a hospital follows guidelines, again, it improves its a chance of being accredited, and this is again very helpful. And then we see one of the questions which clinicians are having of not having time. Sometimes now clinicians are being allocated time, especially for hospitals or facilities which are wrong accreditation. When also people get external expert at the facility level, we see that this really improves the guideline implementation at the local level. Then there is a motivation, there is a multidisciplinary collaboration, and academic discussion, which also help clinicians to use evidence-based intervention and then look at the guideline, then own or just endorse this guideline for the local or the hospital level. Then there is accountability, because now patients also sometimes come knowing already what intervention they need, and then when they start asking, we know that clinicians are again pushed to use the guideline. Next slide. So what do we think is important, or what do we suggest? We know one of the challenges we have seen is awareness. Sometimes clinicians do not know where to find the information. So this is a big challenge. When they're looking at the guidelines, sometimes they go randomly to Google. They will never be able to find the right guide, the right information, and sometimes they don't even get the best evidence, the current evidence available. So this is a very big scenario. This is a very big problem. This is at the global, but also at the country level. So we hope that if at a certain point, if people can know exactly where to go and search for the best evidence, especially like on postpartum hemorrhage, this will just be very helpful. Then there is ownership, where people need to get champions. So it's very difficult for people to implement guidelines if there is no champions at the country and the facility level. So champions is very important. And then there is this involvement of the patient, as I've said, into the guideline development. They need to be involved, but also they need also to have some versions which educate them so that they come knowing exactly what they need. And then another important aspect we need to consider is sometimes this part of the implementation. So some people just develop a guideline, they just publish it, but they are not making sure that they reach the end users. So this is again an area which need to be put, so people need to put more effort. Then mode of communication have to be improved. Then we need summarized field version of the guideline, because sometimes a 200-page guideline will just be difficult for already a busy clinician for implementation. Thank you so much. This is the last slide, please. All right, thank you so much.
Thank you very much for an excellent presentation that gave us an overview of both the development of guidelines and just shows how complex a process it is, and then looked at the challenges globally, nationally, and at facility level. And just three things come to mind from your presentation, David, and we'll be taking questions after. It's not just enough to develop the guidelines. We need to make sure that they're reaching the end user. So that's an important point that you raise. It's critically important at a country level to have champions, people who will advocate for the adoption of new guidelines, and then patients' voice. I was really pleased to hear that you mentioned that, David, that actually women and their families have a role in ensuring that, that these guidelines are implemented in policy and practice. So on that, I'm going to move over to our next presentation. So thanks again for an excellent presentation. I'm going to move over to Dr. Kusum Thapa, who is joining us from Nepal. Dr. Thapa is an obstetrician and gynecologist with a Master's in Public Health and is a Fellow of the Royal College of Obstetricians and Gynecologists in the UK. She's a Senior Technical Advisor for JPIGO, working on the USAID funded mechanism Momentum. So before I go over to Kusum, just want to mention that Nepal has made great strides to reduce maternal mortality over a number of years, and Kusum will be talking about both successes, the challenges, and potentially the way forward to improve the use of guidelines in Nepal. So over to you, Kusum.
Thank you so much, Catherine. Good morning, good evening, good afternoon to everyone. David has already really set the stage by laying it out so well regarding the guideline development process, along with barriers of implementation and the way forward. What I will be doing in the next few minutes is talking about similar issues in the context of Nepal. So, next slide, please. Let me start by giving you a bit of a background of Nepal. Until recently, Nepal was a kingdom in the laps of Himalayas. In the 2015 constitution declared Nepal a federal democratic republic with one federal government, 7 provincial government, as you can see, and 753 local government. The reason I'm mentioning this is this does have implications in terms of guideline, particularly because this is a very recent transition. As you can see here, the maternal mortality, and as also Catherine mentioned, the maternal mortality in Nepal is 239 per 100,000 births, which is live births, which is a decrease from 538 maternal deaths, and since 1993, and Nepal was on track for NDGs. Next, please. Next slide, please. So I will be talking first about the success because we would always like to hear nice things first and then go on to what the challenges are. So the government's scaling up of its PPH intervention program has contributed to a reduction in maternal mortality from due to PPH from 41% in 1998 to 17% in 2009. And this has been possible because of a two-pronged strategy by the government of Nepal, the active management, which has been incorporated in the guidelines as well as in the skilled birth attendant training package as early as 2006. And at this point, I would really like to thank Debbie Ambroster, who was then leading the POPI project, where she really helped build the capacity of professional organizations, particularly of the obstetrician gynecologist and the nurse midwives, to be able to really scale this up in the country. At that point, our facility delivery was only 18%. So the government of Nepal had policies which was then translated into guidelines and into the training of these female community health volunteers for community distribution of misoprostol by these community health workers, volunteers, they are volunteers for home births. Next slide, please. Next. What you can see here is the cause-specific hospital maternal deaths from 2015 to 2019 using the ICD-MM. Next, please. Next slide. Next, yeah. And what you can see is consistently over the years, PPH continues to account for 17% of all these maternal deaths. Next. So even though we have had successes, there are a number of challenges, particularly for when we talk about guidelines. We've heard a lot about the WHO guidelines, and David has really told us also about the challenges. But here I would like to talk about three important things. One is, in the context of Nepal, the infrequent updating of national guidelines. The second point, the second important challenge is there is no systematic dissemination efforts, and there is no efforts even to update the frontline health workers. And at this juncture, one thing which is so very important is that even if there is some dissemination of guidelines and protocols or training, the private sector is really left out of this whole equation. And the other thing is we might be having updated guidelines, we might be having, it might be disseminated, but it's the motivation of these frontline health workers also to be able to use these guidelines and to actively reach out to ensure that they are updated, because there is no cultural requirement for CME, because that's not part of the accreditation of the facility or relicensing of the provider, because once they receive their council registration and their license, that is forever. Now, with the decentralization, which I spoke earlier, it's too early to say whether that's an opportunity or that's a challenge in itself. Next, please. So these are the guidelines which we've seen earlier, the 17 and 18. Next slide. But what you can see here are medical standards, particularly for maternal and newborn care, was formulated in 2007, and it's not been updated since then. There has been now efforts to update it recently, but I mean, this is a big challenge. So when latest evidence come, it becomes very difficult for providers to really follow those, because then it's not reflected in these standards. And furthermore, there is also no policy that standards need to be updated every few years, or when a new evidence comes, it has to update it. There is no policy to within the government to mention that. Next, please. So In Nepal, we normally follow the WHO guidelines, and how that is translated at a country level is basically the WHO Nepal country office receives the guideline from headquarters or from CRO, and that is shared with the different government counterparts as well as with concerned stakeholders and during the technical working group meeting. But beyond that, there is no deliberate effort to disseminate these to those frontline health workers who need it the most. And also now with the decentralized system, it becomes a challenge to really be able to do this in a systematic way within the provinces and within the local government, because they are separate bodies at this point of time. Next. So the Nepal Health Fertility Survey was done in 2016, and they found that the availability of standards and protocols and guidelines at facility level was very low, and so was their use. So you can see that only 28% of all health institutions really had any form of standards, updated standards, protocols, and even job aids. Next slide, please. So there was to ensure that practitioners follow guideline, they have the knowledge and they are performing as per the guidelines and protocols. What you can see here is regarding the infection prevention practices, it's very low. So like hand washing, before, during second stage, and this was a study which was done by Family Health Division and USAID in 2014. So in spite of the fact that for infection prevention, we did have updated standards and guidelines, protocols, we did have lots of these facilities received a whole site infection prevention training, yet the performance was so low. And we did a quick survey. It's a very small sample size, but just to understand what providers, the providers' knowledge. And I think this was also something which was spoken earlier, was what we found that the carbetocin for the prevention of PPH, the knowledge was as low as 34%, and less than 50% really knew that TXA could be used for the treatment of PPH. What was very interesting was 95% knew that misoprostol could be used for PPH prevention. And that could be because we already had that community distribution of misoprostol in the country. So that could have had an effect on this, but they were not aware of the correct dose for the prevention of PPH. So even if they had some knowledge about misoprostol for PPH prevention, they were not aware of the correct dose. Next, please. So what I would really like to highlight here is we have had successes translating our policies into practices, but there is always an ongoing challenges of updating our guidelines and being able to disseminate it to the end user. And in the new context of decentralization, the roles are still clearly not defined, and particularly for the budget, for dissemination, budget for procurement, and even like printing, etc. So these challenges still remain within the country. But as every cloud has a silver lining, we have a few very good policies in place. So we do see some hope there, like nurses, midwives are allowed to give injections. So if we can have a mechanism in which we can really translate this even by virtual or however we could, within the COVID context, be able to update them on this, they could perform it. And the other thing which is really important in the context of PPH is that the medical officers, they receive a 10 weeks training in which the then provide CMOC services in remote districts of Nepal. So if we can really update them, that would be a great opportunity for us. Finally, I would like to really mention that if we are really committed to save our women, it is not enough just to update guidelines. It is important that we ensure that it is disseminated widely, and more important, support the use of, by the frontline health workers, making sure they are adequately trained with necessary resources and supportive policies. Thank you. Next slide is, I think, a thank you slide.
Thank you, Kuzum, for that excellent presentation. And as you mentioned, there's been some really impressive changes in Nepal around PPH, reducing deaths from 41% in 1998 to 17% in 2009. So clearly, really, the use of guidelines and being implemented at the practice level has really helped in that instance. You raised some really critical issues, and as you were talking, it really came to me that the issue around the systems issues and the processes that need to be put in place to make sure that evidence goes from the guidelines that are printed into policy and into practice. Just a couple of issues I wanted to highlight. I thought your point about the private sector really not being part of the dialogue and not being part of the implementation and rollout of guidelines is a critically important issue. The other issue of continuous medical education. Those of us that live and work in countries that have continuous medical education, it really is an incentive. And periodic registration, it really is an incentive to continue with continuous medical education. And then also the issue around when a country has moved maybe from a centralized system to a decentralized system within their health system, how do we operate and how do we ensure that guidelines are disseminated right down to the health facilities, even in the remotest area? So there's a lot of food for thought in your presentation. I want to thank you for that. So our third presentation is going to be given to us from Afghanistan. Dr. Farzana Maroof is a technical advisor working with the Global Financing Facility within the World Bank Group in Afghanistan. She's a very experienced medical doctor with a master's degree in public policy and strategy, and is now pursuing her PhD, where she is studying how to improve the quality of maternal and newborn health services. So a very, very appropriate topic for her. And she will be talking about the strong policy environment within Afghanistan, some successes, but also where gaps still exist. So over to you, Farzana. Really looking forward to hearing this presentation from Afghanistan.
Thank you so much, Catherine, for the introduction and the opportunity to participate in this panel. I will definitely start from a brief background about Afghanistan and the context. Next slide, please. Afghanistan is a landlocked country with ongoing conflict for more than 40 years and worsening security situation nowadays, and a lot of political instabilities. And the country has very low human capital index, with more than 75% of the population living in rural areas. And also around 1/5 of women can read and write, and more than 55% of the population live below poverty line. The health services in Afghanistan are contracted to the NGOs at primary and secondary level, but still there are a lot of inequalities and also imbalances in the human resource, skill, gender, and also distribution within the country. Recently, Afghanistan or the country is affected hugely by the COVID-19 pandemic. Next slide. Despite reduction in maternal mortality in Afghanistan, the country still have very high maternal mortality ratio, around 638 according to the recent UN estimation. And hemorrhage is still the leading cause of maternal mortality in the country, with very poor other indicators, like only 1/5 of women, they have ANC4 visit at the health facility level, and still more than 40% of the women, they give birth at home. And according to the recent analysis done by the Global Financing Facility and also GHU, on the impact of COVID-19 in Afghanistan, it revealed that if we do not maintain the essential services for maternal and newborn health in Afghanistan, there would be a decline in facility-based delivery and also an increment in maternal mortality by 18%, an increase in child mortality by 14% due to the demand and supply shock due to the COVID-19. Next slide. Coming back to the PPH reduction, prevention, detection, and management in Afghanistan, we have a very strong foundation and also comprehensive PPH reduction approach in Afghanistan at both the health facility and also community level. So it also include the health education on birth preparedness and complication readiness, promotion of antenatal care, and encouragement of women to give birth at home with skilled birth attendants. Next slide, please. So having said that, the community-based distribution of misoprostol was piloted by community health workers in Afghanistan since 2014 with very positive results, but with a very smaller scale and attempts in different parts of the country. But the gradual and larger scale up of this program is now planned under the new investment case, which is developed by the Ministry of Public Health, and it is supported by the Global Financing Facility. And the GFF or Global Financing Facility is a partnership. It is country-led, working in 36 countries, and Afghanistan is one of those countries working around government priorities and also advancing the universal health coverage. It is a multi-stakeholder platform to end women, children, and adolescent death, preventable death in the countries. Next slide, please. As I mentioned earlier, we have a strong national level foundation. Like there was a call to action declaration in Afghanistan to reduce maternal death by 2015, and also a position paper to improve prevention and management of postpartum hemorrhage, and also the national RMNCH strategy supports the administration of Eurythmic, availability of evidence-based guidelines, and scope of practice by both CADs, like the signal function of BMONC and prevention, detection, and management of postpartum hemorrhages practiced by doctors and midwives by all cadre. And also there is a national package of competency-based performance improvement, learning materials, protocols, tools, job aids, guidelines available, and the transaminic acid was included in the PPH protocol in 2018. Next slide. So despite having availability of guidelines and also a strong foundation, but still there are some gaps or challenges between the policy and healthcare providers' practices. Like the quality of care study, which was conducted in 2016 in Afghanistan, it revealed that despite 90% of the health facilities, they had Eurythmic, but only around 70% of women received Eurythmic immediately after birth. It means that still around 30% of women, they do not receive Eurythmic for AMSL immediately after birth. And also around 60% of women are not checked for postpartum bleeding or danger signs of postpartum hemorrhage after delivery. It means that the basic practices, they need some improvement. Next slide. Next slide. The same study revealed that there are some gaps in management of postpartum hemorrhage. For instance, the tonic dose which were applied to women, they varied and they were not standardized based on the available guidelines. And also in some PPH cases, tonic was even not provided to the woman. Which means that management of main maternal and newborn complications is still poor in the country, and less than half of the health facilities, they had some of the guidelines like EMON guideline or PPH prevention and treatment guidelines. And also there is a lack of quality improvement and enhancement agenda and approaches at the national level. Despite there were some attempts by off-budget partners and the quality improvement approaches and tools were tested and piloted at a smaller scale, but it was not embedded in the health system and it was not turned like a national program in the country. Next slide. As I said, currently we are suffering from huge COVID-19 outbreak in the country, and also what do we need to improve the quality and coverage of PPH in order to maintain the essential services. So we need the strong leadership and governance in the country, and also the standardized national quality improvement approach and agenda. It is something that recently the newly developed investment case has started discussion with all partners, different partners, both at the public and private sector, and it also includes measuring metrics through different systems such as the balance scorecard, which is currently used in Afghanistan, and also improving the documentation and patient records, having the functional MNDSR system and the centralized decision making. These are some of the attempts that the government is working on that. Next slide, please. And also referring to the context of the COVID-19 and high maternal mortality due to the PPH in the country, we need a competent and also responsive multidisciplinary care teams in Afghanistan at the health facility level, and also to be prepared for emergencies, and also consider the triage, good referral system, and also dissemination and adherence to the clinical protocol for prevention and treatment of PPH. Also the infection preventions, and also we have some evidence that there are some basic supply or PPH commodities are there's shortage of those commodities at the health facility level. This is so important to ensure availability of that, to avoid the supply shock also, and also enabling environment, because there are a lot of gaps regarding the communication and experience of care and at the health facility, especially with this context of COVID-19, and community participation, engagement, dissemination of the IEC materials regarding the PPH and also maternal and newborn complication at the community level. These are very essential in the context of Afghanistan expanding and scale up of some programs, as I mentioned earlier, like the postpartum hemorrhage, to bring care closer to the woman and motivate them to seek care and go to the health facilities. Next slide. In summary, we have most of the PPH framework in Afghanistan, but it needs continuous support and from the government and also from different partners that we have in Afghanistan. Next slide. Having said that, urgent effort is needed to prioritize and tackle the immediate cause of maternal mortality, such as postpartum hemorrhage, and foster coordination in the context of Afghanistan between on-budget and off-budget, that they should work together with a shared accountability and a shorter and also longer term with a collective responses to achieve more impacts with a shared vision, and also to strengthening the health system and work on the social determinants of health, which is outside the health sector, with a multifaceted approach in longer term. Thank you so much. I will pause here, Catherine.
Thank you very much, Farzana, for that excellent presentation. Really helpful for us to know what's happening in Afghanistan. Just one point, by off budget, and just to clarify this point with you, Farzana, for those on the call, for off budget, you talk about activities that are not that are either not driven through the ministry or are not known to the ministry. You know, partners coming, trying to help, but actually are doing things on their own, which is not recognised within the environment. Is that correct? So you're talking about small pilots, etc., that have not been shared with the ministry.
Thank you, Catherine. In fact, I'm talking about these pilots, which are the great opportunities for Afghanistan, the context, like, as you see, a lot of update evidences and also guidelines and everything at the health system. But we have a lot of concern regarding the accountability, the government leadership, and also political instability, turnovers, the capacity, and also government ownership. To turn all these pilots, small programs into a national program with a shared vision that I already mentioned, and prioritize it, because as I mentioned, for the maternal and newborn leading cause of maternal mortality, and to work toward it, we are lacking this. Otherwise, they are coordinated with the Ministry of Public Health and also the other partners.
Okay, thanks very much for that. That's excellent. Because we're running over slightly, I'm just going to take the one question. It's quite a long question, so but I think it's a really critical one. And this is understanding that resources are limited in some countries. Shouldn't one prioritize training of providers with materials derived from guidelines to save a stage of simplifying and summarizing and disseminating guidelines to providers? In other words, providing training materials that are derived from the guidelines, so that providers will be informed and updated. What are your thoughts around that suggestion to any of our three panelists? That would be great to hear your thoughts.
Yeah, can I?
Yes, please do, Kusum.
Yeah. In Nepal, what we normally do is, whatever standards are there, we have training packages for skilled birth attendants, and that is incorporated, the guidelines are incorporated into those training packages. The challenges being those training packages are not updated that frequently. So there are challenges at each level. One is the updating of those guidelines, and then updating of the protocols and the training packages. So I think the COVID context has really taught us in Nepal a very good lesson, because what we had to do was, within a very short time, we had to disseminate our RMNACH guidelines across the country to all the healthcare providers, so that they do not stop essential services. So what we did was, once that was endorsed, we just did a 2-hour session developing a pool of central level facilitators who then cascaded that in each of these provinces. So where I see the next step moving forward, after our experiences with RMNACH and services are now continuing, is that's a great opportunity in which we can quickly disseminate guidelines and key evidence-based practices to our frontline health workers. I think that is something which we had never thought of before, but this COVID context has really taught us that. Okay. So I think that's where I'm.
Yeah. Great, thank you very much, Kusum. Unfortunately, we've run out of time, so I won't be able to go to Farzana and David for their comments, but please, we can answer the comments. So if both of you would like to write your comments in the question and answer section, that would be really great. So thank you all three of you again for your really excellent presentations, and it's really good to hear what's happening at a country level. Thank you. Over to you, John.
Great. Thank you, Catherine and Farzana, David and Kusum. what a fantastic way to end the day, because I think that really kind of drives it home, because it's really about that implementation at the country level, and looking at the identifying the challenges within that, and also